webinar entitled How to Do an Efficient and Effective Chargemaster Review. We appreciate you taking time out of your busy schedules to join us for this 30-minute web session. Before we start, let's cover a few housekeeping items. All attendees have been placed on mute in order to eliminate background noise. We encourage you to interact with our speaker throughout the presentation by typing your questions and comments into the Q&A panel. Your questions will be answered following the presentation as time permits. We may not get to all of your questions live, but we will be providing you with an FAQ document with the questions and answers received throughout today's session, as well as the PowerPoint presented today, and a link to the live recording within 5 business days. Today's presenter is Wendy Kennedy, Director of Revenue Integrity Services here at Vitalware. Wendy, the show is yours. You now have the floor.
Thanks, Julie, and good afternoon, everyone. So as Julie mentioned, today we're going to talk about how to do an efficient and effective Chargemaster review. We're getting into the really busy season, so I thought this would be very timely. So we're going to talk about why to do a CDM review, how often to do a CDM review, planning needs, data needs, what to actually review while you're doing these functions, and then how to make those changes in your CDM. So we're going to start out with why do a CDM review. If I had to summarize why you should do a CDM review in 2 words, those 2 words would be compliance and reimbursement. But today we're going to talk about this in much more detail. We're going to get down in the weeds and talk about why it's so important to set up a cadence for reviewing your CDM and all of the files and the processes associated with maintaining it. The first reason here to do a CDM review is the fact that CPT and HCPCS codes are directly related to reimbursement. So as you're aware, outdated CPT codes result in failed claims, denials, and revenue loss. Failed claims create rework and delayed payment. So obviously, when a claim fails in the system, someone has to work that claim, someone has to review why it failed, come up with a way to fix it, and also potentially figure out what needs to be fixed on the front end to avoid this happening again. And so while all that is happening, you're still not getting paid yet because that bill still isn't out the door. So there's going to be a delay in your payment. Failed claims also cause confusion, especially when we have the big changes going on like we have in January. People may start seeing new things that they've never seen before. And so it might fall into their work queue and they're not really sure how to address the issue. And, we're all under lots of pressures to meet productivity needs. And so oftentimes what happens in these situations is that, we have a $30 charge holding up a $10,000 claim. Somebody strips the charge off the claim just to get the bill out the door. Revenue codes are also directly related to reimbursement. So, many of your managed care payers are reimbursing basing on the revenue code rather than that HCPCS code. So you're getting a 450 ER case rate or 360 OR case rate. So if you have that revenue code assigned to a charge incorrectly, you're also going to get paid incorrectly, which could be to your advantage or to your disadvantage. Clinical departments may be performing services that they're not charging for. So do you have missing charges in your CDM? Obviously, if you don't get a charge on the claim, then you're not going to be able to get paid for that. So oftentimes we hear that departments don't know if they're allowed to charge for something, or someone told them they couldn't 10 years ago and they haven't done it for 10 years. Submission of outdated or invalid data leads to non-compliant billing practices. Obviously, it is a hospital's responsibility to present claims data to Medicare that is compliant and accurate. So if we have inaccurate codes assigned to charges, then we get into a situation where we are submitting false claims. So really looking at the data elements. Incorrect drug units result in revenue loss or potentially overpayments. So, validating that you're getting paid correctly with those units and not getting overpaid or underpaid. Pricing directly impacts your payment. So if you have lesser of charges language in your managed care contracts and you're not charging the amount that they're willing to pay you, you will be receiving less revenue. And now with price transparency, it's super important to look at your pricing because your prices are now posted out on the internet for everyone to see. So patients can go shopping. If you're the highest priced organization, they may go elsewhere. And then clinical staff may not understand how to use their charges. Sometimes, turnover, new people, a lot of times clinical folks are moving around within the hospital. And so really making sure that each department really understands how to use the charges that they have in their CDM. And then another reason to do a CDM review is identifying any system mapping issues. Oftentimes, the order entry is linked to radiology, which is linked to a CDM charge, and sometimes those linkages get broken, and keeping up with evaluating the accuracy of those is super important. So how often should we do a CDM review? We talked about why, so let's talk about how often we should do this. In my opinion, if you're doing it internally, you should be doing it every year. Keeping in mind that the largest number of code changes, as we all know, are getting released and are effective January 1st. So that seems to be where the majority of that workload comes from. But keeping up with those, and then also those quarterly releases are going to ensure that your CDM is well maintained and solidify that you're going to be getting paid correctly. If you're using external resources, such as our RIS team here at VitalWare, we recommend that you do that every 3 years. Any time is a good time to bring somebody from the outside in, because we're not familiar with your hospital. So we ask you tons of questions about how you do things, why we see what we see in your Chargemaster file, to be able to really dig deep into your processes and into your data. So anytime someone from the outside can do that is definitely a good time. Some other things that might trigger you to want to do a review of your CDM might be the addition of a new facility. So maybe you're a 6-hospital system and just purchased another hospital, and so you've got to figure out what does that CDM review, what does that CDM look like? Is there a way to integrate it and into our main CDM? But looking at that and looking for accuracy, and comparing data from that hospital to your other facilities. And then obviously, if you add a new service line or a new department, you're going to want to look at your CDM. You may be providing services in this new department that you provide in other areas of the hospital. So you'll want to mirror the structure of those charge descriptions and similar pricing, if that makes sense. So that's a great time to do a CDM review. Another thing is if you add new services in an already established department. So sometimes we see that a hospital maybe purchases a new piece of equipment. And so with that equipment comes a whole new slew of services that can be provided. And so charges will need to be created for all of those new services. We see this oftentimes too, maybe in an ambulatory surgery center or a clinic, where you add a new physician who is of a new specialty and thus will be offering new services. So a great time to, while you're building that, to also look at the rest of your file. And then obviously, I think the biggest one, if you do a system conversion, and don't look at your CDM, you're shooting yourself in the foot. We see lots of things go wrong. It just is a huge undertaking, so that's kind of expected. But really looking at mapping is super important if you're doing a system conversion, because that's where things need to be recreated and sometimes fall apart. So perfect time to look at your file. And then obviously if you have staff turnover, if you're having a really hard time, keeping staff in a particular department and it seems like it's been a revolving door, maybe you just want to look at that particular department's CDM and look at some charts and see how they're doing. So planning, obviously before taking on a large project like this, you'll want to do some planning. So identify your team. Who is going to work on reviewing the CDM? What is the scope of this review going to look like? What exactly are you going to do? How are you looking at the whole file? Are you looking at just one department? Are you looking at charts? Are you not looking at charts? Are you meeting with each of the clinical departments? So really defining that scope. And then developing a project plan, setting those deadlines so that you stay on track, having weekly status meetings to discuss the project and communicate any barriers that you're having, actually getting things done. And so maybe those need to be escalated up to someone else to help you get on someone's calendar to really sit down and talk about their CDM. And then you're going to want to identify what your data needs are. What kind of data are you going to need and who are you going to get that from? Who is the person or people in your organization that can get you what you need? And then which clinical departments are you going to include? Again, are you going to do the entire CDM or are you going to do a handful of departments? And then assigning staff to each department. If you have a staff of more than one, divide and conquer and assign specific people to specific departments to try to expedite the review process. And then identify how the review is going to be completed. What tools are you going to use? What deliverables are you going to have when you're finished? And then what process are you going to follow to communicate both before you start the project, during the project, and then also after it's finished? Identify if you're going to be looking at claims. I'm a huge advocate. Anytime you are looking at your Chargemaster, it is so helpful to also look at a claim sample, because you've probably heard me say this 1,000 times. You can have the most pristine Chargemaster file, but if people don't know how to charge for the services that they provide, it doesn't provide as much value. So look at some claims, see how they're doing, provide them with feedback when you sit down with those clinical directors and let them know where they're struggling and let them know how to do it correctly. So provide that feedback loop, give them education, and then maybe if you identify a department that does really poorly, then circle back with them later in the year, maybe the next quarter, and see if they've made improvements. And then develop a plan for making the changes in the actual CDM file. Who's going to do that? What actually are you going to do to make that change? And then where will you do it? Do you have a software system you're going to do it there, or are you going to do it in your main hospital system? And then communicate this project overview with those that are involved to ensure you have engagement. So one of the things that we encourage folks to do when we do a CDM review is to have someone, whether that be someone from the C-suite or whoever that project owner is that's bringing us in, make sure that you communicate out to the team, those clinical folks and revenue integrity staff that we're going to be talking to. Let them know we're coming, let them know why we're setting up these meetings and some of the things that they need to do to prepare. Let them know what it means to the organization so that they understand where they fit into the process and why it's so important for them to give us a little bit of their time. Data needs. So let's talk about data needs. So what data are you going to need to access or to obtain to be able to perform the review? So obviously you're going to need the CDM file to do a CDM review. Maybe you don't only have one, maybe you have multiple files. Maybe you have multiple hospitals. Maybe you have a hospital file, a clinic file, an ambulatory surgery center file, and a physician pro fee file. So identifying really, of all the files that you have, which ones are you going to review, and then how are you going to get them? 12 months of revenue and usage is what we usually recommend at a minimum. If you know we haven't turned anything off in 3 years, then bump that up to 36 months so that you can capture all those old things. Pharmacy file, pulling in those ancillary files like pharmacy and supply and lab and RAD to make sure that you can do a very comprehensive review comparing those ancillary files to your CDM files if they are separate. Charge explosion detail report. So looking at the charge explosions that you have created, do they all still make sense the way they're built? Does the service that we're providing when we enter that charge still include all of those components? And are all of the CPT codes and revenue codes and descriptions, are those all still correct? You're going to need your managed care fee schedules for some pricing analysis work that you'll want to do. And then an account list for a claims review sample. So now that we've talked about the actual data, what elements of that data and what process related to the data will you review? So let's talk about what to review when you're doing a CDM review. So I would consider what you're seeing on this screen here, kind of the basics. So you're going to want to look at the CPT and HCPCS codes. So validate the ones that are already there. Identify charges that exist, but they're actually missing the code that identifies what they are. And then looking at the new codes that have just been published, which ones of those will you actually need to build charges for? So sitting down with those clinical departments and saying, they deleted this code, they've come up with all these new codes, but I'm not sure if you're doing all of these services or maybe just one or two of these services. So have those discussions. The charge description and the corresponding code. I think a lot of people forget to look at this. Our software is amazing. It can find an invalid, deleted code. But we also want to make sure that you're validating that if your charge description says chest X-ray, 2 views, that your CPT code says the same thing. Otherwise, we're doing one thing and we're communicating that we're doing something different. And so again, we end up in a compliance risk of submitting false claims. And remember, when we send it out when we build it in the Chargemaster, it's built charge the same way every time we charge it. So if it's wrong today, it's going to be wrong the rest of the year until you fix it. Revenue codes, looking for invalid or deleted revenue codes, and then also looking to see if the revenue codes applied to the charge actually makes sense. Does it go with that thing? Modifiers, your existing modifiers, and then anything that might be missing, so maybe PT, OT, any of those types of modifiers that you might need. And then anything where there's a code that has had a revised description, take a look at those. Make sure that if it changes the way that charge will be used, that is communicated to the clinical departments. Looking at prices, compare them to the APC payment, Medicare fee schedule, and your managed care fee schedules, making sure that you are checking for that lesser of charge language. Looking at charge explosions, those billing unit multipliers or conversion factors, whatever it's called in your particular system, but ensuring that those drug units are getting flipped over to display the right amount of units on the claim so that you're getting paid correctly. And again, look at all of your reimbursable drugs. Make sure they're identified in your CDM. And then a deeper dive, I would say, is looking at device relationships. You know, if I've got that I'm putting in pacemakers, then I better have some pacemaker devices in my CDM. So checking for those types of things, looking for different duplicate CPTs with the same, with the different price. Does that make sense? If it's justifiable, fine. If one's $15 and one is $500, then you should take a peek at that because something isn't right. Charges with no usage for the previous 12-month period. So obviously, like I said before, you know, you don't want to maintain this massive file. So cleaning things up and getting rid of charges that nobody is using any longer is super important. And I know a lot of people get really nervous about turning things off, but it's like a light switch. If you start doing the service again tomorrow, you can flip the switch, validate that everything is still accurate, and start charging immediately. The other thing is that if those charges are left active, then they can be charged. And so you don't want people to have the ability to make an error and send out invalid data on a claim. Compare those ancillary files to your CDM. Is all that linkage correct between the supply file in the CDM and the pharmacy in the CDM and lab, Sunquest, or Singo? Are those all working? Make sure that that linkage is correct and that everything is mapping to the same thing throughout all of those systems. Doing an NDC analysis. Do you have any NDCs that have been deleted? Is the NDC applied to the drug code actually the right one? Validating all of that information that's behind the scenes. Identifying those codes that aren't recognized or they're not billable to Medicare. So do we have in our column for Medicare, do we have codes in there that Medicare doesn't want? So cleaning that up and making sure that we're submitting the right codes to the right payers. And then doing a pricing analysis of your peers. How do you compare with this price transparency? This is the most important thing with pricing that I can tell you is what are your neighbors charging? Because that's where we're living in today's world, is really in this competitive space where our jackets are open and our prices are all out there on the web. Really looking at that and comparing yourselves to your peers. You know, here at VitaWare, we use SAF data to do that. We can do that based on similar bed-sized hospitals, looking at the national average, 50th, 75th, or 90th percentile. Are you a teaching or non-teaching hospital, rural or urban? How do you compare in your state? How do you compare against, you know, up to 20 hospitals that you choose to look at? But really, now is a great time to start taking a really deep dive into your pricing strategy. And then continuing on what to review. Review each department's CDM with that clinical director. Identify missing charges, new charges that you need. Discuss the usage. If you see something where you think they talk about this procedure all the time, that they're always doing it, and you see that last year they only did 3. Seems odd, have the discussion. Something might be broken. They may be doing it, ordering it, and it's not getting charged for some reason. Again, those obsolete charges, turn them off if you're no longer providing the service. Lots of times too, we found like the guidance type procedures, so ultrasound guidance, CT guidance. Oftentimes we hear that, well, we used to do that via ultrasound, now we're doing it only really via CT. So we don't need the ultrasound guided service any longer, so we can get rid of that. If you've finding that you've got deleted codes in there and they did have a replacement code, validate that that replacement code has already been created in the Chargemaster, and if it has, then make sure you inactivate those others. And then when you're sitting with those departments, talk about the chart review. Do the chart review before you talk to them and discuss the results. How did they do? You know, if they did great, let them know. And if they didn't, provide them what they did, what was wrong with it, and what to do correctly. And just really close that loop for them. How are you going to make changes in your actual CDM? Are you going to do those manually in your hospital system? Do you have a software application such as our VitalWare CDM where you're going to do it in the system? Update those charges through, an automated workflow, get the approvals. Do you have a direct interface so they're going to pass over, or are you going to export something out of your CDM software and import it up into your hospital system? I think this is the best option. It obviously helps you create that history so you can see all the changes that have ever been made to your CDM. But really looking at all the options you have that work for your facility. And, I have to brag a little bit, VitalWare's Vital CDM, we have the only CDM management software that in the market that can export a file that is consumable by Epic. So you can do all your work in there, maintain all the history of the changes for every single charge, and then upload it straight into Epic to make the changes in your system. So you only have to do it in one place. And then obviously, if this is something that you're interested in doing or something that you need to do and you need help with, we're here to help you. We have an amazing team of consultants. We use our own software. Let that do some of the work for us. And then everyone on our team has more than 20 years of experience in the industry. We do very comprehensive discussions about not just the CDM, but everything related to it. So how do your charges get in the system? Are you checking the charges in the clinical departments to ensure you've captured everything? And then we deliver those recommendations right back into our Vital CDM workflow that you can use temporarily, even if you aren't a client. And then for 60 days, once you get those results, we'll be around to help you, meet with you once a week to talk about how is it going? How can we help you get these changes made? And then we have the ability to have an interface or exportable updates back into your patient accounting system. So, there's information out on the website about this as well, and a way for you to get a hold of us if you are interested in having us come in and help you get ready for these big changes. All right. Julie, I'll flip it back over to you. I know we only have a few minutes if anybody has any questions.
All right, Wendy, that was great. Wonderful, wonderful information. And at this time, since we only have 2 minutes, for the sake of everyone's schedules and ensuring that you guys are able to go and carry on with your day, we're going to wrap up the webinar. We will, again, be providing an FAQ document with all of the questions as well as answers that came in throughout today's webinar, the PowerPoint presentation, and a link to the live recording within the next 5 business days. So you will be receiving an email with all that information. And if you would like more information on what you saw today, please feel free to reach out to your account manager directly if you're a current VitalWare client, or you can reach out to Wendy Kennedy directly at wendykennedy@vitalware.com. In order to stay up to date on VitalWare's future webinars, we invite you to follow us on LinkedIn, and you can also see all of the upcoming webinars that we have on our website under resources. All of the webinars that we have throughout the remainder of the year will be posted there with a chance to register. So again, thank you for joining us, and we hope you have a great rest of your day. Thank you, Wendy.
Have a great day, everyone.